Hi everyone, this is Dr. Viveris, and we are going to talk about arterial and venous vascular disorders. And we're going to start talking about peripheral circulation. I know in your book they also have abdominal and thoracic aneurysms in this area when they're talking about arterial disorders. We're going to come back to that in another lecture. Right now, I want you to focus on peripheral arterial disease and peripheral venous disorders, and we'll talk about them in the next coming slides. When you care for a patient who you're concerned about their vascular integrity, I want you to approach them as you would any patient, and that's with a good history and physical. So your history, you're looking to pinpoint any of the risk factors that a patient may have that put them at a higher risk for developing peripheral artery or venous disease. And on your assessment, I want you to pay attention to the signs and symptoms of poor perfusion, especially to their lower extremities, where we see many patients present with peripheral vascular disease to their lower extremities, but it can be to their upper ones too. So you're looking for signs and symptoms of poor perfusion. You're assessing for pulse and pulse worthiness, and we'll talk a little bit more about diagnostic evaluation and some of the studies you can anticipate to help inform your concern of venous or arterial vascular disease. You have a great part of your book that covers the diagnostic evaluation for arterial issues in terms of arterial vascular complications, and they're listed here, and the book goes through each one of these really well for you. I do want you to be familiar with them. I think they are evolving. For those of you who are focused on, am I going to test you on each of these? No, but I do want you to know how we utilize radiology and diagnostic evaluation to help determine the progression of arterial vascular disease in patients. If you remember from pathophysiology, peripheral artery disease is a complication of blood traveling to the tips of your toes, that the arteries have a buildup of plaque or can have a vessel injury that causes narrowing of the blood vessel, and blood doesn't travel to your toes as effectively as it should. Venous disease is a complication of blood returning from your extremities, but I want you to focus right now on arterial disease, and this is a complication with blood being able to reach lower extremities, including your hands for upper extremities, but the distal regions for tissue perfusion. So here we're concerned about, is there altered tissue perfusion? Is this causing chronic pain? Do they have more pain with activity? And are they losing some of the neurovascular sensations, so they're less aware of injury to the distal limb, fingers or toes, hands, feet? And are they familiar with how to manage this disease process? So those are some of the nursing diagnoses associated with arterial vascular disease. Our goal with patients who have PAD is pretty clear. We understand there's a narrowing of the vessel, and so there is a lack of perfusion of oxygenated blood to the distal tissue, and our aim is going to be to increase that blood supply. So things that support vasodilation and minimize any additional compression or constriction are going to be included in our planning. Pain in peripheral arterial disease is a significant issue. One of the symptoms we refer to is intermittent claudication, and this is often described by patients as an aching or a cramping that occurs with any increased activity. Patients will have an increase in oxygen demand as they use that muscle group, and because of the stenosis or decreased blood flow to the area, they aren't able to meet the demands of that muscle in terms of oxygen consumption. So the pain is relieved with rest, and they will, for a while, feel better with that. But there is a phenomenon referred to as rest pain. And that's as the claudication gets more severe, the stenosis becomes even more pronounced. Patients will start to experience pain with rest even, often referred to as a burning, and is often worse at night. And this pain is indicative of a progressive disease. This is demonstrating that they're having problems with circulation even without an increased request for oxygen consumption. So as this develops, it's very debilitating for patients. It leads to a lot of sedentary lifestyles, which sets them off for a whole new set of complications. Even opioids, as prescribed, don't sometimes relieve their pain because it's related to ischemia, that even narcotic utilization for these patients doesn't relieve them from their discomfort. The second slide shows you a little bit about, depending upon where their pain is, what blood vessel we're concerned about in terms of aggravating the distal tissue. So if it's a calf pain, we look to the femoral popliteal vessels. If it's in their foot or lower in their extremity, we can go even lower to their popliteal or tibial arterial vascular supply. So it is important to find out where the pain is and how the pain is exacerbated and what helps relieve the pain. Because if it is relieved by rest, there's some things we can do. If it's still persistent with rest, then it is indicative of a more significant complication. The other piece to be concerned about besides pain in these patients is anything that limits your sensory ability puts you at risk for injury and infection. So just make sure to do really good skin assessments on these patients also. I did just mention this, that we're trying to make sure that they're less perfused and less sensory enabled extremity is protected from any kind of injury or infection. So really good diets and strong nutrition help maintain that tissue integrity. In addition, if they are obese, there's a number of complications that come along with morbid obesity, and working to reduce their BMI can help with their peripheral perfusion. This slide is here just to reinforce a lot of what we've talked about when we were discussing atherosclerosis earlier. And little by little, plaque develops on the vessel. And if you can imagine the smaller peripheral arteries, that as this plaque develops, it can become more and more obstructive easily. And in this case, we had a thrombus that got caught in that plaque and completely occluded this vessel. So any tissue that is distal is now not receiving blood supply. And an outcome of that can be gangrene. This is something to be aware of with your geriatric population. They may not present with some of the earlier signs we just talked about, like pain with ambulation, because they may be living a sedentary lifestyle already. Some of your octogenarians aren't up and out of bed walking a lot. So they have a reduced sensorium. They may have peripheral neuropathies, and they may not feel the pain. Some of the first signs and symptoms can be of tissue death. So something to keep in mind as you're caring for the extremes ends of aging. Once arterial vascular disease is identified and peripheral vascular disease, they're very similar risk factors. Our biggest role that we can help add to as nurses is prevention and helping patients modify their modifiable risk factors and to encourage lifestyle changes that help reduce the complications from peripheral vascular disease. So smoking all day long smoking. We know nicotine causes vasoconstriction and adds to the complications of peripheral vascular disease, especially arterial disease. The management of high blood pressure and diabetes, which tie very tightly with obesity and weight management. Activity is a big behavior modification that can improve your vascular status. They even will talk now that each of us should get up in the morning and try to touch our toes, and that flexibility provides information about the plaque and buildup of your blood vessels in addition to your bones and joints, because more rigid venous systems are going to be more restricted in their flexibility. So all of us can be making sure we touch our toes every morning as a healthy lifestyle choice. And then C-reactive protein, that is a blood product that we can measure, and it is elevated in patients who have peripheral vascular disease. So we can keep an eye on those. It's indicative of a lot of vascular disorders. So we can monitor their C-reactive protein and make interventions to help reduce those levels in your blood, which are related to inflammation. There are non-modifiable risk factors that we're aware of. Age, gender, and familial predisposition genetics play a big role in the development of peripheral vascular disease. But as nurses, our goal is to educate patients on these risk factors and how we can help reduce the impact they have on their overall vascular status. For nursing, this is where our role in patient education becomes crucial. We need to advocate for patients to be in physical activities that suit and match their preferences. So it may be walking if you can get patients to walk. It may be seated yoga. Professor Medeiros and I will one day be involved with a seated tap class that I find very interesting, that happens at some nursing homes to keep patients who are less mobile still moving. And I think there's some really interesting kinds of connections that we as nurses can create in terms of educating patients on their well-being and their exercise and activity. These patients who have arterial disease, you actually don't want them to elevate their legs, because that impedes the kind of perfusion that they can get past the stenosis of their vessels. Additionally, you want them to understand how cold impacts their perfusion to their lower extremities, because it also causes vasoconstriction. So making sure they keep their extremities in warm areas that are also safe. They may not have the same sensorium as we have, and you don't want them to be burnt or injured by anything warm. We actually ask them to test their bath water or anything they put in first with their arm, or they're higher in their leg, their knee, than their lower extremity that can't really provide them accurate information about the temperature of water. Again, smoking. Nicotine is probably one of the biggest factors that complicate peripheral vascular disorders. So if we can help them with smoking cessation programs, I think that adds a lot to improving their overall health. Quick knowledge check. So you're the nurse and you're teaching a patient diagnosed with peripheral artery disease. What should be included in your teaching plan? Should you A, help them elevate their extremities, or teach them to elevate their extremities at home? Discourage exercise. C, keep their lower extremities in a neutral or dependent position. Or D, PAD should not cause them pain. So you don't need to include pain as an intervention plan. I know you're all paying attention and you perfectly got that one. It is to keep their lower extremities in a neutral or dependent position, because we want to help get blood to their tips of their toes. This is a traffic problem on the way to your destination. It's not a return trip problem. So for patients with peripheral artery disease, we want them to have their extremities lower or neutral. They will have pain, especially with increased activity. And you do want to have them exercise as much as they can tolerate to help improve their vascular perfusion. All right, we focused on prevention and education, two of the biggest things that are going to help manage peripheral vascular disease. There are some pharmacological interventions that have some I don't want to say effect, but have minimal or moderate effect, I would say. Some patients you'll see beyond Trental or Platal, those are vasodilators, but they help with decreasing the viscosity of blood. They make red blood cells a lot more flexible. So they have some increased travel capacity, I think would be a great way to explain it, that they can get through the stenosed vessels a little bit easier. Plavix helps with making sure your platelets don't aggregate and make the occlusion larger or form clots. And aspirin is also another pharmacological management that's sometimes used. But it's not as effective as you would like to be able to say we can take medication for that and move on. Most times patients end up in some kind of angioplasty where we have to go and remove that area of blood vessel that's so narrowed and replace it with either a stent or a larger vessel that we can use to bypass that area that's causing the complications. So you will see some femoral bypass for patients who have a lot of lower extremity complications with peripheral artery disease. An arterial vascular disorder that I just want to mention that is unlike the chronic vascular disease we've been talking about is called Raynaud's disease. And this is an arterial vaso-occlusion. It usually happens when patients are exposed to cold or emotional issues, and they have a vasoconstriction of the arteries in their fingers or toes. And their fingers will go really white as the vessels constrict. They'll turn blue as deoxygenated blood remains at their distal tissues. And then once that constriction starts to dilate, there'll be a surge of blood that's oxygenated to their fingers and toes, and their fingers and toes will turn red. So it kind of is a 3-color change that is white to blue to red. And as they reperfuse their hands or toes, they have some numbness and tingling and burning associated with those perfusion changes. It is thought that this is more related to a heat regulation issue, that our bodies vasoconstrict and dilate based on our internal temperatures, and that their autoregulation, their thermal regulation is off balance. And this often occurs with women most often occurs with women who are young. Ages 16 to 40 will present with this. So we usually don't have anything we can do besides avoid, or that's indicated, besides avoid the triggers, educating them on how to avoid having their hands or feet exposed in cold temperatures, and how to manage any kind of emotional challenges that they can anticipate ahead of time to reduce the phenomenon. It's still under investigation, but it is an arterial vascular disease, and it always pops up every now and then on NCLEX or somewhere. So I wanted you to be aware of it, that it exists. There's a couple of paragraphs, I think, that you can read of in your book. Now, venous disease is the opposite of arterial disease. So blood has gotten down to the tips of your toes with no problem. But now returning it to your heart so it can be reoxygenated is where the complications start to occur. So understanding that pathophysiology is important. The risk factors are very much the same. Smoking plays a role, hypertension, obesity, diabetes, and activity intolerance. If they are not very active, that venous stasis can cause complications. The things to look for in this are also patients who are not neuro intact, that may have limitations to their ambulatory ability, and be aware of venous thrombosis complications for them too. And then we often put patients at risk for venous thromboembolisms by putting them in the hospital. We put them in the hospital and we put them in their beds. And that extended rest periods puts them at risk for thromboembolisms. We'll talk a little bit about how we can help prevent them. This slide is just a quick review on the pathophysiology. These are normal valves right here that allow all the blood to return from your toes to your heart. And so when the valves close, blood is kept at the next level instead of allowed to flow backwards. But if these valves get lazy or weak, or just by extended blood volume, this vessel gets stretched out and they can't close correctly, you're going to have a pooling of blood that with each beat moves forward and then falls back to increase the volume within the vessels and cause continued complications. Venous thrombus disease is got a couple of hallmark signs related to it, and the pathophysiology has 3 hallmark signs that are referred to as Vischau's triad, and it talks about venous stasis, injury to a blood vessel or the vessel wall, and then a hypercoagulopathic state, which often we find patients post-trauma who have been involved in significant injury. And we've gone into repair and we've tried to help with platelets and blood volume replacement at risk for these kinds of complications. Additionally, the individual comes with risk factors that we've seen and talked about already: age, obesity, prolonged sitting with travel or with being hospitalized, and then cancer and pregnancy also put patients at an increased risk for VTEs. If we are anticipating that a patient has a thromboembolism, we can send them to ultrasound. This is a patent blood vessel right here, nice and round and open. And here's where you can see the venous thromboembolism is hanging out. Here's the full circumference of the vessel, and only blood is being able to return through this little area here. And this is causing a big impediment in blood flow with this clot in the vessel. So before that clot occurs, what can we do to mitigate their risks? This is where you have patients who are in compressive devices, that we put them in their pneumatic stockings and keep them plugged in when they are bedridden. We start early anticoagulant therapy, and you'll see a lot of Lovenox utilized with these patients, or Coumadin for extended therapy, but we send a lot of patients home on Lovenox injections if it's going to be for a moderate amount of time. And that we can help mitigate this a lot in nursing if we ambulate them often, and if we position them often, and while they're in bed, encourage them and their family members to help them participate in exercises that they can do in the bed or passively. Our role as educators is crucial here too. Patients don't necessarily put together that laying in bed is bad for you. They don't understand that you can decondition for each day in a bed by 3 days of your normal performance, especially in the elderly. So it does take a conversation with them that you're not just trying to get them out of bed and walk when they don't feel good, but you're actually doing something to help protect them, just like their medication protects them from things getting worse physiologically. Ambulating them and walking them will also. It is important to be vigilant on following up on blood tests. An important thing to look for are your anticoagulant indicators if you're monitoring PT-PTTs or if you're monitoring INRs, to avoid any additional complications like falls from patients attempting to ambulate on their own, and to have patients really understand that any alcohol or recreational drug use can also cause complications as they go home post-operatively or post-medical management. Another interesting thing is Coumadin, which we use for long-term management for patients, is very dependent on vitamin K. So foods they eat, but also a lot of herbal supplements can impact the effectiveness of that medication. So recognizing what a therapeutic INR is for these patients and why it's important to mitigate their diet and other over-the-counter medications they ingest is important. Okay, so here's a tricky one. Which patient is at the highest risk for venous thromboembolism. Okay, highest risk. When you read that, I need you to recognize that means each of them may be at risk, but who is at the highest risk? Do you think it's the post-op patient? Do you think it's a patient with a central venous catheter who is septic? Do you think it is a 71-year-old who's otherwise healthy? Or the prego, the 30-year-old pregnant woman who's due in 2 weeks? Dun, dun, dun. So although I think 71 is still pretty young, it is a risk factor related to age. So he was in the running too. But the most sick of them, or at least the most at risk, I should say, is the 25-year-old. Because he has a central venous catheter, that puts him at risk in and of itself to have a venous thromboembolism. In addition to the fact that he's septic, so that pathophysiology puts him at risk too. So our other patients only had one risk factor, and this 25-year-old has two. So that put him at highest risk for a VTE. I would expect him to be in compression stockings, receiving Lovenox, and really watching his volume status to make sure we keep him well hydrated. And then patients who are in the ICU and have had significant injury, sometimes we do talk about temporary greenfield filters for those. They're a bit controversial now, so you may or may not see them in your practice, but those are kind of like screens that we put in at your femoral vessel so that any clots that are coming from your lower extremities don't travel high enough to cause more complicating injuries to your lung, heart, or brain. I think one of the under-recognized activities that we should focus on is how we can help patients at home and in the community with this kind of complication. Also, we have a lot of patients that we visit with home health nurses who are pretty sedentary, and that they may make it in the morning from bed to the breakfast table and then to their recliner, but their length of time sitting is pretty extended. So educating patients who are discharged from the hospital or ones that you see in the clinic that you know have limited mobility on how they can help prevent having thromboembolic complications is an important piece. So utilizing family members, utilizing activity logs, trying to encourage them to be as active as possible. An interesting study is going on at UMass Amherst that's looking at how long patients sit at home and what we can do in their environment to encourage them just to get up more times, even for shorter periods, to help with venous return and perfusion issues.